Well, good day, everyone. I am here to talk about cannabis and cancer care, and I do have a number of disclosures to disclose, and there they are. So the Siberian ice princess is a body that was exhumed under the ice in Siberia, felt to be 2,700 years old. Under an MRI, this well-preserved woman is aged at about 25, and she's found to have breast cancer with bone metastases. Around her waist, she has a rope at the end of which is a pouch in which are the flowers of the female plant of Cannabis sativa, suggesting to the archaeologists or anthropologists or whoever makes these assumptions that the ice princess may have been using cannabis 2,700 years ago to treat symptoms associated with her metastatic breast cancer. If we look at more modern times, a recent study published just this year looked at 612 women with breast cancer responding to a survey. 42% said that they used cannabis for medical purposes. Only 23% said it was strictly medical, meaning that there was some recreational component as well. Three quarters reported that cannabis was extremely or very helpful in relieving their symptoms. The symptoms shown on the left: pain, insomnia, anxiety, stress, nausea, and vomiting. 80% used cannabis during their active treatment, and over 50% in their survivorship mode. 49% said cannabis is also being used to treat the cancer itself, and we'll talk a little bit more about that at the end. So just a little background on cannabis. This is a very versatile botanical that's been used for millennia. It was available in the US up until 1942, when it was removed from our pharmacopoeia. In 1970, under the Controlled Substances Act, cannabis was placed in Schedule I, meaning high potential for abuse and no accepted medical use. The plant itself contains over 400 different chemicals, including 120 21-carbon terpenophenolic compounds known as cannabinoids. In addition, the terpenoids give the strains their characteristic odors, and the flavonoids are also present with significant potential pharmaceutical activity. Just to review some of the cannabinoids, delta-9 tetrahydrocannabinol, or THC, is felt to be the most psychoactive component of the plant. Cannabidiol, or CBD, has catapulted to the top of the most favored cannabinoid list because it's felt to be not psychoactive. It's probably present in the plant to modulate the activity of the THC. Cannabinol, which is a breakdown product of old delta-9 THC, is becoming popular lately as a potential sleep aid. CBG has many of the same qualities of CBD, and THCV I think is quite interesting because it decreases appetite, apparently for food, for alcohol, as well as for opiates. Delta-8 THC is, like delta-9 THC, psychoactive, and it's running into some problems now because it is available in states that are not allowing cannabis sort of slipping in under the rug. We and all animal species down through sea squirts have cannabinoid receptors in our body. The cannabinoid 1, or CB1 receptor, is the most densely populated G protein coupled 7-transmembrane domain receptor in the human brain. It's also present throughout the body. The CB2 receptor was originally found in the cells of the spleen and the immune system, natural killer, and B lymphocytes. Tetrahydrocannabinol, or THC, complexes with the cannabinoid receptors, but CBD in fact does not. CBD in fact changes the shape of the cannabinoid receptor so it can no longer bind with the THC. So cannabis in chemotherapy-induced nausea and vomiting, interest was prompted in the 70s, an era when Jimmy Carter was president. More people were using cannabis. It was prior to the Reagan Just Say No campaign. And young people with young people cancers, i.e. Hodgkin's disease and testicular cancer, told us that cannabis was better than our then available antiemetic prochlorperazine. So a small drug company in conjunction with the National Cancer Institute developed tetrahydrocannabinol as an antiemetic. And dronabinol, synthetic THC, was initially approved in 1986 for treatment of nausea and vomiting associated with chemotherapy. A synthetic analog, nabilone, was also approved at the same time. The indication for dronabinol was expanded in 1992 to include the treatment of anorexia associated with weight loss in patients with the AIDS wasting syndrome. So currently, the available cannabis-based medicines from the pharmacy are dronabinol, which is available in both a pill and a liquid form, nabilone, and cannabidiol has recently been approved as Epidiolex, a highly purified plant-derived CBD that's indicated for treatment of refractory seizures in children. Nabiximols is an interesting product. It's a whole plant extract that's been modulated to have a 1-to-1 ratio of THC to CBD. It's licensed and available in Canada, the UK, European Union, Australia, and New Zealand for treatment of spasticity associated with multiple sclerosis. As yet, it has not been approved in the United States because all clinical trials here have not demonstrated any effectiveness. So when we talk about cannabis, the botanical, there are many different delivery systems. Inhalation, I believe, is the best way for patients to have control over the onset, the depth, and the duration of the effect. When you inhale cannabis, the THC concentration peaks in 2.5 minutes. When you take it by mouth, ingest it as an edible, for example, it takes 2.5 hours. And when ingested by mouth, the delta-9 THC gets converted in first-pass metabolism in the liver into an even more psychoactive 11-hydroxy metabolite. So again, I tell patients if they want better control over the onset, the depth, and the duration, inhalation is better than oral ingestion. And when I say inhalation, I don't mean vaporizing a liquid. I think vaporizing the plant material is quite healthy and safe. I don't like inhalation of an oil. Now there are many dispensaries that provide tinctures and oils that patients put in the mouth, and initially something gets absorbed sublingually that recapitulates the pharmacokinetics of inhalation. The rest is then swallowed, which provides similar kinetics to oral ingestion. Topical THC and cannabis preparations are available. How they work is unclear to me. Many of my patients are making suppositories from coconut oil and cannabis plant, and they definitely say that it has activity. So we know that nabilone and dronabinol are licensed and approved for treatment of chemotherapy-induced nausea and vomiting. What about cannabis itself? Although I have many patients who forego more standard antiemetics to use cannabis, there are only 3 controlled trials in the literature. And in 2 of them, cannabis was only available after dronabinol, its main psychoactive component, had failed. The third is a difficult study to interpret altogether. There is a very small study of nabiximols, the under-the-tongue spray, with a 1-to-1 ratio in 16 patients, showing that the spray was more effective than placebo in conjunction with standard antiemetics. An interesting study in non-cancer patients presenting to a GI clinic asked them to rate 29 antiemetics on their efficacy, and cannabis scored highest, outscoring ondansetron. What about appetite? Anybody who went to college in the 60s remembers the munchies. Well, dronabinol unfortunately doesn't reproduce the same effect on appetite that cannabis, the whole plant, does. In a randomized double-blind study, one of the largest studies of dronabinol, comparing it to magestrol in patients with cancer cachexia, the dronabinol was inferior to the magestrol, and in fact, when they were given in combination, appears to have decreased some of the benefit of the magestrol. 2 ongoing, more recent studies have also not supported either nabilone or a capsule containing oil-based THC and CBD as being useful in supporting appetite and increasing food intake. Although both of these studies showed improvement in quality of life, social functioning, less pain, fatigue, and insomnia. So one question that I'm frequently asked is, should I take THC or CBD? And I think I've alluded to the fact already that I think that the plant provides the real medicine in giving a so-called entourage effect. where it's not only the cannabinoids, but the flavonoids and terpenoids that are contributing to its pharmaceutical benefit. The Netherlands pharmacies provide 3 different strains of cannabis for consumption, 2 high THC and 1 low CBD. And when people were surveyed as to which was best for increasing appetite, it was not the high CBD cannabis. And this corresponds with data collected from the Relief app, which is an app where patients can self-report symptom changes with the use of cannabis. And in this particular study, dried flower was most commonly used and was associated with greater symptom relief. Only higher THC levels were associated with greater symptom relief and prevalence of positive and negative side effects. CBD potency levels were not associated with either symptom change or side effects. CBD has developed into a $23 billion business in this country with very little data to support. Cannabinoids and pain, it's felt that the reason that we have our own cannabinoid receptors and our own endogenous cannabinoids, similar to endorphins, is to help us process noxious stimuli. And elevated levels of the CB1 receptor, like the opioid receptor, are found in areas of the brain that modulate noxious stimuli. CB1 and CB2 agonists also have peripheral nervous system analgesic activity, and cannabinoids, as well as the terpenoids and flavonoids, may have anti-inflammatory effects, and we all know anti-inflammatories are often analgesic. The analgesic effects of cannabinoids are not blocked by opioid antagonists, suggesting that they do work via different mechanisms. The largest body of evidence for cannabinoids in pain comes from use in neuropathic pain, particularly HIV-related peripheral neuropathy. There was a small study showing benefit in diabetic neuropathy, and preclinical models suggest that cannabinoids can not only treat, but can prevent chemotherapy-induced peripheral neuropathy. And this is the only study published in the literature of a cannabis-based medicine so far. There is one more that I'm going to discuss. 16 patients with chemotherapy-induced peripheral neuropathy were randomized to nabiximols or placebo in a crossover pilot. As you can see from panel A, there was actually no difference. However, they looked at a responder analysis. 5 people reported a greater than 2.6 or greater than 2-point drop on the 0 to 10 scale of pain. So they calculated the number needed to treat for 1 to benefit would be 5, suggesting further research is needed. This is the other study I was mentioning, but it's not a randomized placebo-controlled study for sure, but an observational study, retrospective, of Israeli cancer patients. 243 receiving 5-FU and oxaliplatinum combinations were using cannabis at the time they were getting chemo, and 265 were not. And the cannabis users were divided into those who used cannabis prior to receiving the neurotoxic oxaliplatinum and those who received cannabis after oxaliplatinum. Grade 2 to 3 chemotherapy-induced peripheral neuropathy was significantly decreased in those who were exposed to cannabis, and particularly more pronounced in those who used cannabis prior to getting chemotherapy, suggesting that the preclinical model that cannabinoids may decrease the frequency of chemotherapy-induced peripheral neuropathy is certainly worth studying. Patients receiving cannabis were also able to tolerate more chemotherapy. Other cancer pain besides neuropathy has been studied mainly using nabiximols. And this is one of the reasons that it is not licensed and available in this country, because 5 studies, now 6 studies in patients with cancer-related non-neuropathic pain have shown no difference between nabiximols and placebo for change in pain. Now, an interesting area that I've studied myself with my group is the question of cannabinoid-opioid interactions, because in rodent models, there is synergy such that 1 + 1 = 5 with pain reduction. So we did a small pharmacokinetic interaction study of 11 patients on sustained release morphine and 10 on sustained release oxycodone, who were subjected to vaporized cannabis for 5 days in our General Clinical Research Center. Plasma levels of the opiates were drawn on day 1 prior to exposure to vaporized cannabis and on day 5. And you can see that if anything, the plasma concentration of the morphine was slightly decreased on day 5, whereas the oxycodone curves were superimposable. So if the level of the opiate decreased or stayed the same, you would expect pain to increase or stay the same. And in fact, overall, we saw a statistically significant 27% reduction in pain, but the study was not powered for pain as an endpoint, so this is an interesting trend. Now, turning to the question of, does cannabis cure cancer? Where does that even come from? It's very popular in social media, and it really dates back many years ago. Investigators from Virginia Commonwealth University published in the Journal of the National Cancer Institute in 1975 that delta-9 THC, delta-8 THC, and cannabinol all inhibited Lewis lung adenocarcinoma cell growth, both in vitro and in mice. Interestingly, CBD led to increased growth of the tumor. Since that time, there's an increasing body of preclinical evidence suggesting that cannabinoids may have anti-cancer activity. And the plant itself is somewhat of an antioxidant and anti-inflammatory, and those are two things that I usually recommend to most of my patients with cancer before, after, and during treatment. Multiple tumor cell lines are inhibited in vitro. And when you take nude mice without an immune system and transplant human tumor xenografts, all of these different types of cancers have been shown to be inhibited. Most of the evidence comes from Guillermo Velasco and Manuel Guzman in Madrid. Their lab studies the effect of cannabinoids on metabolism. And the most metabolically active cells in the body are the brain. So they would grow up rat brain and add cannabinoids. And they said, maybe we can do our work faster if we grew up a glioma. So they did grow up a rat brain tumor, and they added cannabinoids, and everything died. Since that time, they've done very elegant research, which shows that the cannabinoids complex with the cannabinoid receptor on the tumor and induce apoptosis, programmed cell death. They've also demonstrated that cannabinoids inhibit vascular endothelial growth factor, or VEGF, decreasing angiogenesis. And finally, they've shown that cannabinoids block the enzyme matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. Sean McAllister here in San Francisco published a number of years back that triple-negative breast cancer cells express increased levels of ID helix loop helix proteins in vitro. These helix loop helix proteins control processes related to tumor progression. In vitro studies demonstrated that CBD downregulates ID1 expression in aggressive breast cancer tumor cells, and this led to a San Francisco headline that pot compound seen as tool against cancer. I can't tell you how many triple-negative breast cancer patients came to see me asking me if they should use CBD to treat their breast cancer. The only study in humans that has been published to date that shows the possibility of a benefit to using a cannabis-based medicine is this study of nabiximols, again, in patients with glioblastoma multiforme that had recurred. 12 patients used this whole plant extract under the tongue spray with a 1-to-1 ratio of THC to CBD. 9 patients used placebo while they were getting dose-dense temozolomide for treatment of recurrent glioblastoma. Interestingly, at 6 months, 2/3 of both groups had recurred. But at 1 year, the survival in the nabiximols group was 83% compared to 44% in the placebo recipients. This is statistically significant, although the study is not powered for survival as an endpoint. It has led to the launching of further clinical trials to look at whether or not this can be reproduced. So many of my oncology colleagues say, gee, Donald, smoking a medicine in the 21st century? We know that tobacco leads to increased risk of lung and head and neck cancer. I was one of the 16 members of the National Academies of Science, Engineering, and Medicine committee that wrote the health effects of cannabis, and cannabinoids were reviewed 10,000 publications in the medical literature. And we found evidence of no association between cannabis use and lung as well as head and neck cancers. Something that oncologists also worry about is pulmonary aspergillosis. I've been an oncologist for 38 years. I've never seen a case in one of my patients. A case control study in HIV patients published a number of years back demonstrated that looking at HIV patients with aspergillosis in their bronchoalveolar lavage was mainly associated with severe neutropenia, immunodeficiency, steroid use, and prior pneumocystis infection, and cannabis use was not associated. One area that I am concerned about is the potential for drug-botanical interactions. THC and particularly CBD inhibit cytochrome P450 isoforms, more of them inhibited by CBD, in fact. So my patients taking highly concentrated oils of THC and CBD in hopes of curing their cancers run a risk of perhaps making other drugs that they're taking, including possibly oral cancer agents, more toxic. The Israelis, again, have reported 2 studies looking at their patients who are using cannabis in association with checkpoint inhibitors compared to patients who are not. And they reported initially that the cannabis patients seem to have a decreased response to the checkpoint inhibitors with regards to their tumor, but in a more recent study, they actually showed a very dramatic negative effect on survival that I think is difficult to actually get your head around and may be related to other confounding differences in the groups. So finally, Ilana Braun did a study of 400 oncologists, 63% responded, 80% reported that they conduct discussions with their patients about cannabis, 78% that said the discussions were patient-initiated. 2/3 viewed cannabis as a helpful adjunct to standard pain management, and 2/3 thought it was equally or more effective than standard therapy for anorexia and cachexia. Less than half, however, recommended it clinically. 1/3 only felt sufficiently informed to make such recommendations. And in the recently published study of women with breast cancer, 39% discussed cannabis with their physicians, mostly, again, patient-initiated, and 1/4 of the patients felt uncomfortable having this conversation. So in summary, despite a dearth of published evidence related to barriers to research, because cannabis, the plant, remains Schedule I in this country, high potential for abuse and no accepted medical use, botanical cannabis may be a useful adjunct to standard treatment in alleviating side effects of cancer or its treatment, perhaps superior to the more widely studied isolated cannabinoids. Although preclinical findings are promising, there is no convincing evidence in the medical literature to date supporting any anti-tumor activity of cannabis or cannabinoids. More research actually should be done exploring the direct impact of cannabis-based interventions on malignant tumors. Perhaps as we study the molecular profile of all of our tumors, we might consider doing CB1 and CB2 assessments as well. Oncologists' concerns about the use of cannabis during cancer treatment can mostly be allayed, and additional research and education is always warranted. And with that, I'll thank you for your attention.
Great, thank you, Dr. Abrams. Our final speaker for this session is Dr. Nicole Simone. She will be presenting on the impact of diet on tumor progression and response to cancer therapy. She's presenting virtually, and she's at the Thomas Jefferson University. Do we have Dr.